I think I'm going to get started now. I'm Dr. Judy Regensteiner, Distinguished Professor of Medicine and Director of the Ludeman Family Center for Women's Health Research. And I'm delighted to welcome you to our new tonight's edition of Let's Talk, Conversations about Women's. Let's Talk is a lecture series created by the Ludeman Family Center for Women's Health Research in partnership with UC Health, for whom we are incredibly grateful. We are delighted to bring you this special program virtually. With women historically excluded from research studies, there are many unanswered questions, but we study women's health and sex differences, particularly in the areas of cardiovascular disease, diabetes, and the intersection of mental and physical health. We're committed to a future in which research includes women and men and accounts for sex and gender differences. We do this through research, by mentoring, and through educational events. 10 years ago, Let's Talk was created to educate the community about health through evidence-based talks. Each of the lecture series is uniquely created and presented by scientific and medical experts. This evening, we're celebrating Heart Health Month, and for this special Heart Health Month, we're focusing on how to prevent your heart, the ins and outs of stroke, cardiac arrhythmias, and the connection between mental health and cardiovascular health. We have fantastic speakers with us today, Drs. Layne, Dylla, Wendy, Tzou, and Kevin Masters. Please type any questions you have in the Q&A. For those of you who are not familiar with our format, we're going to have all three talks and then have a panel Q&A at the very end. So please type in your questions to the Q&A and we will be sure to answer them at the end. Our first speaker tonight is Dr. Layne Dylla, MD, PhD. Dr. Dylla has a passion for medicine and using research to advance her treatment of many patients. She's pursued this passion for medicine and research as a dual MD, PhD student at the University of Colorado in the Medical Scientist Training Program. Dr. Dylla subsequently completed her emergency medicine residency training in dual experimental therapeutic and emergency medicine research fellowships at the University of Rochester Medical Center, and we are happy that she rejoined us back in Colorado. Since residency, Dr. Dylla has focused on stroke treatments in the pre-hospital and emergency department settings, where she began to address the disparities in care and research between men and women with stroke. Tonight, Dr. Dylla will touch on the underlying biology of stroke and stroke risk factors. She will particularly emphasize the differences between men and women in terms of stroke care and outcomes, and how we can combat these disparities. Thank you very much, Dr. Dylla.
Thank you for having me. I'm going to go ahead and share my screen, and please let me know if it doesn't look like it's showing up right. That was a wonderful introduction, and I really appreciate it. And I appreciate being here to talk with you guys today. I am going to tell you guys a little bit about how I got to be an emergency medicine physician studying stroke, because I am not a neurologist, and this was not necessarily my intended career path, but it makes sense in the end, and I promise there's a reason for it. So I started out studying fruit flies and developmental biology as an undergrad in New Mexico State University. And what I realized through this research was that to understand diseases, you have to understand basic biology. And to take that a step further, to understand how we're going to treat diseases, you have to understand how the biology goes wrong in the pathophysiology of diseases. And so with that, I moved up to Colorado and did a dual MD PhD program looking at Ewing sarcoma. And while this was very interesting, and I realized that the treatments that we had we not understood the pathophysiology of Ewing sarcoma, the treatments wouldn't have worked appropriately. It wasn't connected to emergency medicine. And so I went on to do an emergency medicine residency training in Rochester and stayed on for an experimental therapeutics and combined EM research fellowship as well, and really got interested in the fact that stroke is a time-critical illness. You have to intervene in these patients because time is brain, and yet we ignore the pre-hospital and emergency department setting. And so today, I'm hoping that we'll focus a little bit on the early phases of stroke and what we can do to minimize our risk of having a stroke and the treatment options thereof. And then, of course, the sex differences that are also under-recognized. All this would not be possible without a tremendous amount of help from family, friends, mentors, and especially the Ludeman Center for Women's Health Research. They provided funding for my research in multiple aspects, and Dr. Regensteiner has been a key mentor for me through the University of Colorado Building Interdisciplinary Research Careers in Women's Health Birch K-12 Award. So the goals of today's talk are to understand the major types of stroke, to describe the risk factors, clinical presentations, and treatments specifically for acute ischemic stroke, to appreciate the differences in the pathophysiology of ischemic stroke, to identify gaps in treatment based on gender, and identify some of the personal actions you can take to decrease your stroke risk as well. So what is a stroke? At the most basic principle, a stroke is something that disrupts the blood flow and oxygenation and energy supply to the part of the brain that results in some sort of compromised neurological function, which you may be able to regain some, or it may be lost forever. There are two main types of stroke, hemorrhagic and ischemic. Hemorrhagic strokes are the minority of strokes. They account for about 20% of all strokes. They're typically associated with uncontrolled blood pressure, hypertension, aneurysms or outpouching of blood vessels, and smokers. And so if you see in this diagram, what happens in a hemorrhagic stroke basically is you have a blood vessel. It either has defect in the wall lining that causes an outpouching or an aneurysm, or you have uncontrolled hypertension, which eventually stretches that blood vessel wall. And the blood vessel ruptures. And when it ruptures, not only do you now get decreased blood flow more distally to the tissue that was being perfused by that blood vessel, but the blood itself is very irritating and causes inflammation, swelling, and edema, and damages the surrounding brain tissue. There are limited treatments for hemorrhagic strokes, and they're mainly aimed at controlling the bleeding and controlling the swelling. But like I said, these are the minority of strokes and not really the focus of my treatment or research. The second type of strokes are ischemic strokes. These are the vast majority. Over 80% of all strokes are ischemic in nature. And what this means is that you have some sort of blood clot, and there are two different ways you get that blood clot that prevents blood from getting more distally to that tissue. The two main types are embolic and thrombotic. So embolic, you get a blood clot that forms in your leg, like a deep vein thrombosis, or one that forms in your heart because your heart doesn't beat and contract normally and the blood gets stagnant and clots, and then it flicks off and goes to your brain. Embolic strokes typically happen in younger patients who have a communication or between the right and the left sides of their heart, so what we call a patent foramen ovale. And they're typically associated with atrial fibrillation. So in atrial fibrillation, like I said, the top part of your heart, the atrium, don't contract normally. And so that allows the blood to kind of just sit in the bottom part of your heart and form a clot, which can then flick off and go to the brain. The second type of ischemic strokes are thrombotic in nature. And so these are kind of what we think more similar to like your heart attacks. So you have a plaque or an atherosclerotic blood vessel. And so you have narrowing of that blood vessel anyways. And over time, you'll get some sort of additional blood clot or break off a piece of that plaque that then breaks off and prevents full blood flow past that clot. This is typically more common in the elderly patients. So what does this actually look like? So we talked about it's a disruption in blood flow. And what happens is when you don't get oxygen to that brain and you don't get blood flow, you get a portion of the brain tissue shown here in black called the infarct core. And that tissue has got so little blood flow, so little oxygen that it dies off pretty quickly. And there's really nothing we can do to bring that tissue back once it's dead. But surrounding that tissue, you have a larger area of what we call a penumbra. So tissue that's maybe not getting quite as much blood flow as it normally was, not enough oxygen to really perform like it should. But we have the chance to actually salvage that tissue. So if we can restore blood flow, that tissue will come back and regain its function. And that's the tissue we want to focus on when we're thinking about treatment of stroke. In terms of what it looks like when you see a patient or clinically, we say think fast. And that means the face. So we typically see a facial droop, arm weakness or numbness, tingling, leg weakness, numbness, tingling, changes in your speech, both your ability to communicate with others and get the words out, and the ability to understand speech that's spoken to you. So people may be talking to you, asking you to do things, and you can't follow the commands because you don't actually process what they're saying. And we know that stroke is time critical. So anytime you see these symptoms, it's time to call 911. 1.9 million neurons are lost every minute that a stroke goes untreated. So this is not a disease where we have the luxury to wait and see, are my symptoms going to get better? Is this going away? Is this just, I feel bad and it's going to get better? It's a disease where you need to call 911 immediately. And specifically because there are treatment options for ischemic stroke that are limited time windows. So when we talk about the clot busting drug, TPA, that can only be given within 4.5 hours from the time your symptoms started. When we talk about ways that we go in and physically remove the clot in that blood vessel to salvage that penumbra tissue, that can only be done up to 24 hours in select patients. 24 hours sounds like a long time, but you would be amazed at how few patients we actually treat with either TPA or endovascular because they're outside of the time window. Why do I care about stroke? Stroke is the leading cause of death and disability worldwide, and it's specifically in the US. It's an impact in quality of life for patients and their families. So not only do these patients die, which is awful in and of itself, but a lot of times they actually survive, but have very severe compromised neurological function to the point where they're not able to eat for themselves. They require feeding tubes, breathing tubes, people to help go to the bathroom, that kind of stuff. So it's more than just the mortality of stroke. We also know that it's a large number of patients every year are having a stroke. So 795,000 patients a year have a new or recurrent stroke. That equates to one stroke every 40 seconds. Approximately half of all strokes are going to come in by an EMS or a pre-hospital provider, and the vast majority are going to be admitted to a hospital through emergency department. So while I'm not a neurologist, I would argue that this is my wheelhouse for both clinically and in research. So talking about how do we, since we know stroke is devastating, how do we combat this disease and how do we prevent it? There are what we consider both modifiable and non-modifiable risk factors. In terms of modifiable risk factors, this accounts for about 90% of all your stroke risk. Within the modifiable risk factors, lifestyle factors, things that you completely can control, account for about 3/4 of that risk. So for example, smoking increases your risk of having a stroke 2 to 4 times. When you quit, it takes about 10 years or so for that risk to go back to normal. So you can modify that. You can quit smoking and improve your chances of not having a stroke, but it takes time. Having a sedentary lifestyle, less than 4 times a week exercising, increases your risk about 20% or 1.2 times the risk. We know that a Mediterranean low salt diet is protective. And interestingly, having just one sugary beverage a day increases your risk by 1.13%. So 13% increase in your risk compared to someone who doesn't drink sugary beverages. Other modifiable risk factors are your chronic illnesses. So high blood pressure or hypertension increases your risk about 2 to 3 times. Diabetes and uncontrolled blood sugars increases it about twice. Dyslipidemia or high blood cholesterol has a more variable impact. And some of that has to do with the fact that it's also can be a non-modifiable risk factor. We'll talk about that a little bit more in a second. Things like chronic renal disease, being on dialysis increases about 1.43% times. And then atrial fibrillation, which our next speaker is going to talk about too, and cardiac arrhythmias, increases your risk of stroke anywhere from 2 to 5 times, depending on your sex actually. And atrial fibrillation, again, it's just this where your heart doesn't quite beat normally, and so you're more prone to form a blood clot. In terms of risk factors that we cannot control, race and ethnicity are a big one. So African-American women have one of the highest rates of death. African-Americans in general have the highest rate of death due to stroke. Hispanic ethnicity increases the risk of stroke. Genetics, so there are genetic conditions that make you more prone to form blood clots. There are genetic conditions that make your blood cholesterol be higher and more prone to stroke. And then what we're going to focus on kind of for the remainder of the talk is sex. So the lifetime risk of females between the age of 55 and 75 is 1 in 5. Women are at increased lifetime risk of a stroke. They typically have their strokes later in life, when they're age 85 or older, whereas men typically have their strokes at age 55 to 75. This typically results in a higher impact on their quality of life and morbidity and mortality. So women, because they're having their strokes later, in part, are less likely to have the good social support networks that men typically have when they have their stroke. They're less likely to have someone living with them to help recognize those symptoms. There's often delays in when they call EMS to get to the hospital. And like I said, it's about 1 in 5 women are age 55 to 75 are going to have a stroke. And while we made great strides in improving the incidence and decreasing the incidence of stroke in men, that has not held true for women. Women still have an increased morbidity and mortality compared to men. It's estimated that by 2050, about 70,000 more deaths in females are going to happen compared to males. And when we put this in perspective to something that we all think about frequently, breast cancer, stroke actually kills twice as many women as breast cancer. So this has a significant impact on our loved ones, and we need to think about not only how we're treating women compared to men with stroke, but why there's this disconnect. This disconnect actually starts in the pre-hospital setting and continues throughout the care of the patient. One of the most recent studies that I've done is looking at compliance with the American Stroke Association guidelines for pre-hospital care. So the American Stroke Association has 8 metrics that they say anybody we think is suspected of us having a stroke, we should be performing these metrics. Those include documentation of a stroke cell, so looking for that facial droop, that arm weakness, et cetera. And when it is there, pre-notifying the hospital. So the hospital can rally the resources, get the neurologist in the ED, get the CT scanner ready, et cetera, and be prepared for that patient. We look for mimics, so looking at low blood sugar, looking to make sure their heart is in a normal rhythm by performing a 12-lead electrocardiogram, giving oxygen when they need it, documenting when those symptoms first started, and then minimizing the time that we're spending with these patients on scene. So it should be less than 90 seconds from the time that EMS is called to the time that they're en route to that patient. And it should be less than 15 minutes when they're on the scene with that patient before they're transporting to the hospital. And in some areas, women do better than men. So encounters involving women, about 71% are likely to have a blood glucose check compared to only about 70% in men. But in many other areas, women do worse. So when we look at having an EKG performed in the pre-hospital setting, only about 19% of women encounters involving women will have an EKG obtained, whereas about 20 to 21% involving men will have an EKG obtained. When we look at the on-scene time, we see that an on-scene time less than 15 minutes only happens about 45% of the encounters involving women versus 46% of encounters versus in men. And when we look at overall concordance with all 8 metrics, the numbers are dismal. So only about 0.3%, so less than 1% of all of our EMS encounters nationwide are fully compliant with our American Stroke Association guidelines. Slightly better for men, so 0.4% versus 0.3%. And while these numbers are low, and it doesn't sound like these are big differences, this disconnect continues throughout the hospital. So in the pre-hospital setting, women are 18% less likely to receive the quality of care that's fully compliant with American Stroke Association guidelines. When they come into the hospital, women are also then less likely to receive diagnostic imaging and therapeutic interventions, such as the clot busting and medication TPA, despite the fact that women actually do better compared to men when they do get the TPA. And so even these small differences, when you compound them over the course of a patient's hospital stay, add up. So why is there a discrepancy? One, as I mentioned, those initial presentations of a stroke may vary. So we typically think of that, think fast, that facial droop, arm weakness, speech changes as our classic symptoms. Women are less likely to present with those symptoms. They're more likely to have pain or facial numbness, generalized weakness, dizziness. They're more likely to present later after their onset of symptoms. And then their response to therapies also varies. We also know that the risk factors vary with biological sex. So it's not just how we treat them. There is underlying biology that plays into it. So for example, atrial fibrillation and coronary artery disease, in women, that increases your risk of having a stroke 5 times. In men, It only increases it 2 times. So there is fundamental underlying biology that differs. We know this is true based on some of our preclinical mouse research. So one classic example that I like to point out is the case of minocycline. Minocycline is an antibiotic that has anti-inflammatory properties. And when they studied it in male mice, they showed great promise. They had smaller infarcts, so a smaller amount of brain tissue lost. They had better functional outcomes. But when they put it in a human trial where you had both men and women, because it's a human trial, they deemed it not effective. When they went back and looked at that human trial and looked at the effect in men versus women, they found that minocycline, yes, is effective in men, just like it was effective in the male mice, but they didn't test it in the female mice. And in females, it's not effective. So when you put those results together, they deem that treatment as ineffective. There are very few studies that evaluate the role of biological sex and aging in male and female mice. We know that when you do study this, we see that they activate different cell death pathways in response to stroke. They have a varied immune response. So females are more susceptible to free radical damage and inflammatory response to stroke. They're also more susceptible to immunosuppression and being able to fight off stroke-associated infections like pneumonia afterwards. So it's not just how we treat them, it's the biology as well. And so this is where I'd like to kind of have a call to action for us, both as clinicians and as researchers. To effectively combat this disproportionate morbidity and mortality that women face over the course of their lifetime, we have to understand the biology as it translates to outcomes. We have to treat and explore the biology of mice as it translates to humans of both sex. We can no longer continue to have basic science research only in young male mice. It doesn't translate. We need to understand the gender-based disparities in care and place emphasis on providing quality of care to both men and women from the point of pre-hospital intervention to discharge. We cannot accept that women are going to be less likely to receive guideline concordant care. And we have to understand why it is that they're receiving this different and inferior care. So what can you do to take action and prevent your stroke? One, know your stroke risk factors. So control your cholesterol. If you're smoking, quit smoking. It takes about 10 years to neutralize your risk, but it does come back to normal. Exercise 4 times a week is the recommendation. It reduces your risk by about 20%. Cut out the sugary beverages, control your blood sugar. And if you have something like atrial fibrillation or a clotting disorder where you're more prone to form blood clots in your legs or your lungs, talk about how you can manage it. Do you need to be on a blood thinner? And then the last thing I would implore everyone is monitor for stroke symptoms and act early. Time is brain. We don't have the luxury to wait and see if your symptoms are going to get better. You need to get to the hospital immediately. And so to wrap things up, I have a couple of resources, some really good websites that I think you can explore. The CDC Government for Wise Women, and there's a stroke org that gives you more information about stroke. And with that, I'd like to thank the University of Colorado School of Medicine, my mentors, Dr. Gende, Herson, Poisson, Rice, and Regensteiner, who have all helped me with some of this initial research and continue to help me. And then, of course, funding for my research as it goes on. And with that, thank you. I will stop sharing.
Thank you very much, Dr. Dylla. That was great. And, you know, those of you who are listening to the introduction know that this is Heart Month. But when we think of the heart, we think of the whole cardiovascular system, which includes the brain, the heart, and the peripheral arteries as well. So that talk was excellent, Dr. Dylla. Remember that we will have the questions at the very end of the session. So we're going to launch right into our second talk from Dr. Wendy Tzou. Dr. Tzou is a cardiologist. She's associate director of the cardiac electrophysiology laboratories at the University of Colorado Hospital. She's an associate professor at the university as well. She has a passion for and expertise in management of complex arrhythmias. And her clinical practice includes a comprehensive range of contemporary device and arrhythmia management. She has participated in multiple service programs and initiatives intended to improve awareness and treatment of patients advocated by the American Heart Association and the Heart Rhythm Society. She has also participated in collaborative preclinical and clinical research designed to optimize techniques and outcomes of complex catheter ablation procedures. An important thing that Dr. Tzou would like to say about her life is that she's inspired by having a 10-year-old girl and an 8-year-old boy, and they inspire her multiple times a day. And her inspiration is to try to make health and life better for all people when she looks at her children, which is a lovely statement. And without further ado, I'm introducing Dr. Wendy Tzou.
Thank you so much. That was a beautiful introduction. And thank you again for having me to try to share some of my thoughts about important differences with respect to arrhythmia presentations for men and women. These are my disclosures. And I want to start with a case. This is a very common presentation case, not just for patients that I see, but patients that I hear about. So I'll read the script. So the doctor says, how have you been feeling? This is a 74-year-old woman who's presenting just for a routine exam, just routine follow-up. And the patient says, oh, fine, I guess. The doctor says, really? Your EKG today shows that you are in an irregular heart rhythm called atrial fibrillation. Can you tell? The patient, who is quite surprised to hear that anything's abnormal, says, no, I can't feel it. Well, so when you look at the spectrum of symptoms and the severity of symptoms in patients who have atrial fibrillation overall, as well as in particular, men versus women with symptoms and atrial fibrillation, at least that are reported, there's, I feel like it's unfair to ask a patient this question of, can you tell that you're in an arrhythmia, when they don't know rather really what that means. So this type of study, this is an epidemiologic study from Europe, that looked at a group of patients with atrial fibrillation in multiple centers, and they looked at the differences in symptoms between men and women. And what you can see is that there are, pretty substantial differences in presentation. This scale that we use to assess the severity of symptoms or the severity of activity limitation. So it's developed by the European Heart Rhythm Society. The United States has a similar kind of scaling system. Women are more typically presenting with more severe symptoms. They are more commonly presenting with palpitations and a sense of fear and anxiety in relationship to atrial fibrillation. In fact, this is kind of a pet peeve of mine, is where women are just told that they are just anxious as a reason for feeling the symptoms that they're feeling related to the arrhythmia. And overall, they score more poorly when you look at overall health assessment by subjective, or I guess I should say quantitation of subjective symptoms. Overall health status scores are lower, psychological status is lower, physical status is lower. So I, as a physician, when I encounter a patient like this, and this is someone who's already been sort of screened by their primary care physician, is referred to me, I'll press them more about what I believe are the actual symptoms. So I'll say, have you noticed feeling more tired or short of breath with activities? Very common answer, not just for women, also for men. Well, yes, but I'm out of shape, I'm 74, I had COVID this year, etc. Isn't this all normal? Well, I would say it doesn't have to be, and we shouldn't accept that it has to be. So what exactly is atrial fibrillation? So this is a diagram of the heart with the front part cut away. I'll start with what kind of normal rhythm is. So you've got the two top chambers here, which are called the atria, right atrium, left atrium, and they are separated by the valves from the ventricles, which are the big pumping chambers of the heart that pump blood to the major organs. So normal electrical activation of the heart occurs up here in this sinus node region, and these cells are very specialized. They're called pacemaker cells for a reason, because they drive the beating of the heart most of the time. So electricity emanates from here, activates all the cells in the atria, and then the cells react by contracting, so the chambers contract. Once that is completed, the electricity gets set down this, what we call electrical bridge, or what I call an electrical bridge, of which most people only have one, through which then the activity or the electroactivation is disseminated through this highway system, otherwise known as bundle branches, to the many more cells that exist in the ventricles. And so then the top squeezes and the bottom squeezes, and that's normal. People who have atrial fibrillation, and actually other people too, can have random firing occur from other places outside of the sinus node. But people who have atrial fibrillation tend to have abnormal firing from locations within the pulmonary veins. And what that looks like is, literally there will be cells that are in the pulmonary veins that start to become irritated and just fire. And what that does in the beginning is just really causes some ectopic beats, things that we call premature atrial contractions, because the origin of activation is from the atria. Over time, that repetitive sort of firing that's higher than normal in frequency can then lead to little runs of fast heartbeats. And then it can progress over time to actually sort of like igniting a fire in the atria of the heart. So, or an electrical storm is what I call it. So then what happens then is all the cells then stop listening to one another. They stop caring about what the other is doing, and they are all firing at will randomly. And so what then can happen is that these chambers then literally fibrillate mechanically. The good thing about this electrical bridge, which transmits the electrical information from the top to the bottom to then stimulate the bottom to squeeze, is that it actually filters out some of this information, such that not all of the chaos in the top transmits to the bottom, which is protective. Otherwise, a lot of people with atrial fibrillation would not be alive because their ventricles would be fibrillating. And it's the ventricles that are responsible for our pulse, our blood pressure, our state of consciousness. But what can still happen is that rapid transit of information can happen across this bridge, this AV node, such that what one may feel, even if they can't feel symptoms in the chest, is that the heart is beating rapidly and irregularly. After time, when the heart, and especially the atria, get used to having atrial fibrillation, the episodes start happening more frequently and occur for longer durations of time. These cells actually start acting up more mechanically in addition to electrically, and they start to produce scar tissue, which then can enlarge the chambers, can produce other areas of triggered firing, and can lead to flutter circuits that happen within these areas. Without interruption, this can proceed to a state of permanent atrial fibrillation, where the effort to restore regular or sinus rhythm it exceeds the benefit of doing so. And again, I highlight that the major symptoms that usually are experienced in most people are more insidious and easily attributable to other disease processes: shortness of breath, fatigue, and exercise intolerance. Less so, I would say, palpitations, and in particular, continuous palpitations and chest discomfort. Common comorbidities, and we'll discuss this a little bit more later, include obesity and obstructive sleep apnea. It is impossible to ignore effective treatment of atrial fibrillation without addressing these common comorbidities, because they can not only precipitate the propensity to have atrial fibrillation, but they can make it harder to control. The major health risks that we work to prevent, because to some point, some of these are modifiable, but once you have atrial fibrillation, we have to work to prevent the bigger health deals, including stroke, which our previous speaker just spoke so eloquently about, heart failure. With rapid rates of the ventricles pumping here, the heart, like any other muscle, is able to get tired, and you can actually develop heart failure in the setting of prolonged atrial fibrillation episodes with very fast heart rates and other cardiovascular events. This is a global problem. This is, in 2017 alone, there were 3 million new cases diagnosed around the world. And the worldwide prevalence is, just under 40 million. And when you consider a worldwide population of just under 8 billion, that's not an insignificant number. And this number is probably underestimated. When you look at the distribution of diagnosis by sex, it's clear that across all ages, for the most part, men are diagnosed more with atrial fibrillation than women. But women are the ones who suffer more. So you can see that the mortality rate in each of these age categories, especially above the age of 75, is higher for women than in men. Now, why might that be? This was brought up in the prior talk, that there's a significant mortality difference associated with atrial fibrillation, and a lot of it is tied to stroke. So this is an epidemiologic study. So they followed a group of healthy people within Framingham, Massachusetts, over a period of time. None of them have atrial fibrillation at the beginning, but those who developed atrial fibrillation clearly had an increased risk of mortality. And women actually had a significantly increased risk of mortality compared to men, twofold increased risk versus 1.5 increased risk. And part of this is related to recognition of the fact that there is an arrhythmic problem going on. Because if you don't recognize it, one of the treatments, which I'll talk about here shortly, to kind of prevent the major risk factor associated with mortality in atrial fibrillation might not be implemented. And therefore it might not be that surprising actually that people who go undiagnosed but have a problem then that then is untreated go on to have greater problems. So treatment options, anticoagulation. Dr. Dylla described very nicely this concept of stroke, and stroke related to atrial fibrillation tends to be a real big one. So this is this is an ultrasound image of the heart obtained from the esophagus. So you can see here, similar to the diagram I showed before, this is the left atrium, the right atrium, and the ventricles. This pouch here, the left atrial appendage, you can see how, all the cells in the atria are doing what they want to do. There's no clear flow of blood from the top to the bottom. And what can happen in a pouch like this is that blood can pool and clot. And so anticoagulation is our first defense against one of the major morbidities with atrial fibrillation. And it's important to note that aspirin treatment alone is inadequate. So if you see a provider, they diagnose you with atrial fibrillation, and they are worried about bleeding, which is totally reasonable, but they say, you know what, why don't you just take aspirin? It's not the same as taking a blood thinner. Blood thinners up to date were warfarin, but now there are other options that are equivalent to warfarin in terms of minimizing the risk of these types of large blood clot forming, and which are also sometimes associated with less bleeding than warfarin. Rate control I mentioned, so if we can work to control the heart rate, the squeezing rate of the ventricles, that's one way to help treat atrial fibrillation. That can be done with medications, or in more advanced cases with an ablation to basically obliterate the communication electrically, take out the bridge, and in which case a pacemaker is indicated. Or rhythm control, which is basically trying to restore what is normal. So trying to get the AFib to be less likely to happen and have the regular pacemaker cells, sinus node, or normal sinus rhythm kind of ensue. And this can be done with a combination of medications, what we call a cardioversion, which is basically like a reset button for the heart electrically, where we deliver energy to reset all of the electrical cells, and then the place where heartbeats typically originate will then wake up and then start to act again. And then more complex ablations to manage atrial fibrillation. Notably, pacemakers may also be needed in each of these categories, even if we don't do this simple ablation, which we call an AV node ablation. So important to recognize differences in treatments. With respect to anticoagulation, which I just mentioned, has been the mainstay, repetitively demonstrated in multiple trials to prevent morbidity and mortality in patients with atrial fibrillation, are less prescribed in women than in men, despite the fact that they may have higher stroke risk as well as similar bleeding risk. This is data that demonstrates this, registry data from the United States. And you can see across the board that women are prescribed anticoagulants less than men. Overall, there's a poor rate of prescribed oral anticoagulants based on kind of where people fall in risk, but women seem to suffer more than men. With respect to treatment differences, so overall, I would say that there is no curative treatment for atrial fibrillation. I treat it like high blood pressure or diabetes, and there's not anything that is definitively curative. Recent data has shown that rhythm control is actually far superior to rate control in terms of improving long-term outcomes, including strokes as well as survival. So when someone says or deems that you don't really have symptoms and your heart rate is controlled, I guess I am more skeptical about it. And I like to prove that that's true before I just abandon, the thought of proceeding with more invasive or more aggressive strategies, I should say, which include invasive treatments for rhythm control. So this is medical claims data from a 4-year period within the United States, a large population of patients. You can see that overall for this group, Ablation was offered only less than 30% of the time, more than twice that number were men recommended to undergo ablation. And this was, women were also more likely to be treated with medications, and in particular, rate controlling medications. These are the beta blockers or calcium channel blockers that you might hear about if you have atrial fibrillation and are seen in a clinic. And this is despite the fact that women have a higher CHA2DS2-VASc risk, a higher incidence of prior stroke. So how do we perform a catheter ablation? It is truly a group effort. This is a view from the control room of one of our electrophysiology laboratories. Here is the patient on the table with the fluoroscopy arm here. This is our EP physician. We have a team of anesthesiologists as well as a team of nurses and technicians who participate in the cases. In the control room, you can see that we can see all of the electrical signals within the heart, and they are projected on a system which we call an electroanatomic mapping system, which basically allow us to replicate and see directly, without directly seeing, the inside of the heart, as well as the electrical activation that is occurring within it. And this is an example of a map that we're taking. So we've got electrodes on these catheters, which can measure electrical signals in the heart, as well as stimulate the heart. And we can get an idea of basically the entire anatomy of where we're roaming within without actually having to open the chest or do anything surgically, which is pretty remarkable. And then we can tailor our ablation treatments around this. Now, ablation in recent times has really, or actually I should say early rhythm control in recent times has really come to the forefront in terms of improving outcomes in patients who are early diagnosed with atrial fibrillation. So this was a trial that included patients who were diagnosed with atrial fibrillation within a year, and they had an elevated stroke risk based on the traditional risk factors that we use. And they were randomized to either this rhythm control method, where we really tried with medications or ablation to get people back in sinus rhythm as soon as possible, or rate control, which is, you know what, I don't know, we just control the heart rate, it'll be fine, and institute blood thinners. This was actually probably the most female represented trial I've seen in cardiology in a long time, and possibly ever. And ablation was actually only performed in 8%, at least within the first year of randomization. What they found at those patients who were treated with aggressive therapy to try to get people back into normal rhythm did better in terms of really hard outcomes. And that includes cardiovascular death, stroke, hospitalization for heart failure, and decompensation due to acute coronary syndrome. Also of note is, in which I've not seen with prior ablation trials, is that the stroke rate was significantly reduced in patients who underwent rhythm control as an early option. Other rhythm control considerations, particularly applicable to women, is that certain medications can prolong what we call the QT interval. So that is the time when the ventricles or big pumping chambers have squeezed, and they're sort of relaxing to get ready for the next heartbeat or the next stimulation. Excessive prolongation in that interval can actually lead to dangerous arrhythmias. And there are certain drugs that are used for antiarrhythmic control that can actually predispose women way more than men to these dangerous arrhythmias. And with respect to ablation complications, so there does tend to be a pattern for increased complications with respect to ablation in women compared to men. And that may tie to some of the hesitancy in offering this type of therapy. It's also, I think, silly to think that the ablation strategy that works in men can automatically be applied to women, but that is often done in many centers. So another case to consider is a 75-year-old woman with increasing palpitations. She has worn a monitor, and these are normal beats here. And then she has this run of fast stuff, which is labeled by the monitor as supraventricular tachycardia. So she has also had a long-standing history, more than 10 years, of shortness of breath, intermittent lightheadedness, basically anxiety is what she was told. And she was treated with anxiety medications for these events before she was referred to me. And I, upon seeing this, recognized immediately that she had an arrhythmia that could ultimately be cured. And so at the time of study, which we discussed and she decided to undergo, this was ablated successfully. So supraventricular tachycardia, or SVT, I mentioned what was normal before. I mentioned as well that there can be impulses that arise from the atrium or ventricle in all people normally. But in people who have the predisposition to have a circuit of reentry or an arrhythmia circuit form, that can actually lead to, this SVT. So this bridge structure can actually over time evolve differential properties which promote this type of circuit. It is in fact the most common SVT etiology that's seen in adults. You can also have random firing, just like in the AFib example. And you can also have an extra electrical pathway whereby you have these different, along the valve plane, different structures that have different electrical properties that can predispose to the same issue. So in women versus men, AV&RT predominates. And it's because various studies have shown that they have the predisposition, for whatever reason, to have those differential conduction fibers develop down the bridge that can predispose to those circuits. And in men, it's the opposite. So if they have that extra bridge, they're more likely to have what we call AV-RT, so an SVT that involves the accessory pathway. In atrial tachycardia, it's kind of a mixed sex distribution. With respect to hormonal influences on SVT, which is more predominantly seen in women, there is definitely a large proportion of women who actually have arrhythmia timing related to their menstrual cycles. And when we talk about doing invasive studies to try to get rid of the arrhythmia, part of that depends on being able to induce the arrhythmia in the first place. And if we can't induce it, then it's a no-go kind of proposition. So I want to talk about ventricular arrhythmias and heart disease because it occurs a lot less in women than in men, as far as we know. And that's because women tend to have less heart attacks. Primary prevention ICDs. So these are devices that are meant to treat a very dangerous arrhythmia should it happen in the context of a heart attack or in other forms of heart disease that cause the heart function to be abnormal. And there have been a number of really great studies that have demonstrated the benefit of defibrillator therapy for all populations compared to just regular therapy. But it's important to note that it's difficult to apply these results in women. 16 to 32% of the people enrolled in these trials, in fact, were women. And when you go forward to look through who has received an ICD and who benefits, women probably benefit the least. So when we talk about people who have a low functioning heart or ejection fraction, and someone's talking to you about implanting an ICD, this is a discussion that probably needs to be had with a greater time involvement to discuss risks versus benefits. So we've kind of discussed various differences with respect to atrial arrhythmias as well as ventricular arrhythmias, and there's so much more to talk about, but I will pause here and just thank the audience for their attention and their interest.
Thank you, Dr. Tzou. That was terrific. It's impressive how many differences there are, and yet there are no sex-specific clinical guidelines really in care. And that's something I'm becoming very, interested and concerned about. So you certainly touched on some of the differences, and that was terrific. So thank you.
Thank you.
Our last but definitely not least talk tonight is from Dr. Kevin Masters, who's a clinical health psychologist. And Dr. Masters is here to remind us that whatever goes on in the body is influenced by, the mind, and that mental health does influence physical health and vice versa. And that's one of the focus areas for the Ludeman Center. Dr. Masters is a clinical health psychologist and an international leader in the fields of health psychology and behavioral medicine. He's currently investigating how meaning and purpose may be leveraged to increase adherence to healthy behavior regimens. He's the Colorado principal investigator on the Enhancing Lifestyles for Metabolic Syndrome study, a multi-site randomized trial of lifestyle interventions for treatment of metabolic syndrome. In the lab, he is studying the possible influence of meaning on cardiovascular function during stress and how pre-pandemic lab values predict stress response during the COVID-19 pandemic. Like a lot of people around here, Dr. Masters loves the Colorado outdoors in all its many forms, skiing, hiking, cycling. Since it's Heart Month, it might be good to mention that he does the triple bypass every year, which is an amazing heart race over 3 mountain passes. So I'm very impressed, and we'll turn things over to you, Dr. Masters.
Thank you, Judy. I'm really happy to be with you here. Let me see now. I got to find my slideshow thing here. I can't see it. The banner is covering up my there we go. Okay, great. Well, I'm going to talk a little bit about the psychology of the heart. As Dr. Regensteiner mentioned, I'm a clinical health psychologist. And my particular area that I study is cardiovascular behavioral medicine. It's also called cardiovascular health psychology, sometimes behavioral cardiology, a whole bunch of different ways of describing basically this idea that heart function and mind or psychological functions are in fact related to each other. I should mention a couple of organizations that have been helpful in our research and funding it: the American Heart Association, the National Institutes of Health, and also the Ludeman Center, which funded some of the research that we will talk about when we get to the end of our talk and we talk a little bit about SCAD. So I've titled my talk, The Psychology of the Heart, with a little asterisk there, the one in your chest, because when we talk about psychology and heart, it's kind of good to know, are we talking about the literal heart, the one that's in your chest and beats blood and keeps you alive for your years here on earth, that essential, magnificent pump that we have? Or are we talking sort of metaphorically? The heart seems to get into a lot of metaphor. For example, we talk about the heart of the matter when we're talking about something very serious, or we might talk about Hank Williams famously singing about your cheating heart. So apparently your heart can be up to no good at times. We talk about heartache, and we even talk about having a broken heart. And it turns out that there actually is a very interesting syndrome called broken heart syndrome that relates to emotional functioning in the heart that we will talk about in just a minute. But in terms of tonight's talk, I'm going to try to do about 4 things. First of all, we're going to look at the question of, can psychological states, be they acute or brief or short-term or more chronic and long-term, can those affect the physical heart? Is it only negative psychological states that are important, or can we say something about positive psychological states as well? How do these psychological factors influence heart function? And then finally, can this pathway go the other direction? Can the heart affect psychological states? Now, I want to mention a resource that some of you might find of interest. This is from the American Heart Association. They recently issued a scientific statement on psychological health, well-being, and the mind-heart-body connection. And much of what I'm going to say, really, if you say, well, I don't remember what he talked about or what he said, if you go back to this scientific statement, quite a bit of it will be mentioned in there. They do a very nice job of summarizing a lot of research. And I would call this an article a very accessible article. I think you don't need to be a trained physician or a trained psychologist or a trained statistician necessarily to read through it and understand what they're saying. All right, can acute negative psychological states affect the physical heart? Well, we've all probably heard stories of some individual that receives terrible news, unexpected news, and they seem that this terrible news seems to be associated with a quote unquote a heart attack, maybe even hospitalization or maybe even death. But how do you study something like this? Now, these are stories, they've been around probably forever. Actually, even tonight, I was watching review of the Olympics, and they were talking with one of the coaches, and the coach said about the athlete the coach was coaching, I thought she was going to give me a heart attack. So there's this sort of this connection out there in the folk literature, but how could you really study this? I mean, is that possible? Well, back in the 1990s, some cardiologists in Japan and also at Johns Hopkins, and in particular, Dr. Eileen Wittstein, observed through various measures, including echocardiograms, that some of these patients they have that looked like they were having a heart attack weren't actually having a heart attack, but they were having something happen in their heart that was causing the heart not to function correctly. And when they took a look at it, what they found, and I don't know if you can see my cursor, hopefully you can. On the left side here, we have this left ventricle of normal shape. This is obviously a drawing of everything. And then on the right side, we have a ventricle, but this is one that doesn't look quite right. It's got this kind of ballooning down here, and it's enlarged a bit. And the Japanese physicians noticed that it actually took on the shape of something that they used to catch the octopus, which is called a takotsubo, if I've said that correctly. And so they started calling this takotsubo syndrome. And in the United States, they were noticing the same thing. And it's been called takotsubo cardiomyopathy, broken heart syndrome, stress cardiomyopathy, or apical ballooning syndrome, lots of different names for essentially the same kind of thing. But what were the characteristics of this? Well, there was that characteristic change in the shape of the heart and corresponding dysfunction. This also seems to occur in the context of excessive amounts of stress hormones, but in the absence of the typical kind of blockages that people often talk about when they're talking about a heart attack, but yet the patient experiences symptoms very similar to a heart attack. You can see listed there. Interestingly, and where this becomes important for us in terms of our conversation, is these incidents seem to be often associated with extremely stressful emotional and or physical incidents. Now, again, it's very difficult to study these kinds of things. And when you ask people questions, we often try to find some sort of cause or reason for what happened. And so it could be that these reports aren't entirely accurate, but yet the data has been accumulating for a number of years that at least some reasonable percentage of these cases seem to be caused by these stressful responses. And interestingly, at least so far, the research tends to show that it's more common in women, some say up to 90%, and particularly more common in women over the age of 50. Now, these people aren't exactly having a heart attack, and most of them will survive and be fine after a month or so of healing, but not always. Sometimes it can lead to further problems, serious problems, and even in some cases can lead to death. So this is probably maybe the most acute and striking example of emotions affecting heart, but it's also a rather rare kind of thing. What are some of the more commonly studied or more common types of interactions between psychological factors and the heart? So let's talk about a few of those. And one of those that we might talk about is perceived stress or perceived chronic stress over time. And we're going to talk for just a minute about stress reactivity, or that response that we have when we're the physical response that we have when we're experiencing some type of stressor. So, of course, when you're doing a talk, you look for things related to your talk. And in Sunday's paper, I saw this where the fellow says, "What's that?" And the man says, "Results of my physical." Says, "I need to lower my cholesterol." And he says, "Well, you should stop yelling at me." And then the man says, "Well, that's blood pressure, but thanks for your concern." Well, actually, in the psychology world, we would say, yeah, that's blood pressure, and it might also be cholesterol and some of these other things as well. So I'm going to talk about the stress reactivity and recovery hypothesis. So this is a hypothesis that suggests that when there's a provocative or stressful stimulus, individuals experience characteristic changes, typically increases. There's a little bit of research now going on about folks that blunt or don't have a response when they probably should in a normal sense. But typically you have increases in blood pressure, heart rate, various hormones or stress hormones or chemicals, and vasoconstriction, which is a narrowing of the blood vessels. Now, in the reactivity and recovery hypothesis, we're interested in two things. We're interested, first of all, in the magnitude of change. So what about those people that have abnormally large responses to stress? They really fire off. Is that a risk factor? Or what about the duration of the change? One of the interesting things, like other mammals, we react to stress. A zebra who sees a lion approaching and starting to trot a little and heading in a fast gallop toward the zebra will have a stress response, appropriately so, and will take off. And in a few minutes, the zebra will either be not a zebra anymore, or the zebra will have escaped the lion. And then what does the zebra do? Does the zebra sit there and think about it a lot and worry about it and stew on it, maybe get mad at the lion? No, the zebra goes back to eating, grazing. Recovery is pretty complete and pretty quick. If you have dogs, you've probably seen this with your dog. The dog can get all riled up about something. You bring the dog inside, maybe give them a little tiny treat, and they lay down, and that's it. Their paw flops around, they're ready to sleep. But we humans aren't necessarily like that. We can have that person cut us off in traffic, and then they maybe flip us off because they don't think we're driving the way they think we should drive. And the whole incident is over in 5 seconds or 10 seconds, except that you can go into your office and you can think about it. You can think about it all day long. You can re-experience that stressor many, many, many times, and you can stay in a non-recovered state, we might say, or in a stressed state. So we were interested not only in how big is the response, but how long does it last? And we think that both of these, and there's evidence that both of them are related to cardiovascular disease and even to mortality. At this point in time, the research is stronger on the reactivity, excessive reactivity side of things. But I think that's partly because the recovery research is just a little more difficult to do and is a little behind the reactivity research. But I'm going to talk to you about a couple of studies that you might find interesting. This is a study that was done in Spain, roughly 64,000 adults in primary care, and they did not set out, these were not psychologists, and they were not setting out to study stress, reactivity, and anything to do with cardiovascular disease. In fact, what they were trying to see was whether clinic-based blood pressure measures, those readings you get in your doctor's office, versus an ambulatory-based blood pressure measure, that reading you get when you wear a device around with you for a day, in this case it was 24 hours, how well they would predict all-cause, that's death from any cause or death from cardiovascular disease. And they suspected that the ambulatory measures would predict a bit better. To do this study, they divided their sample into 4 groups. And the group of most interest to us for tonight's talk, and in the interest of time, I'll go quickly and kind of skip the others, but is this group called having white coat hypertension. So this is this group of people who, they go into the office to get their blood pressure checked. The office setting, something about seeing a doctor, maybe the whole white coat, the whole situation, up goes the blood pressure. But when they measured them over time, when they're just in their own natural sort of state, they did not have elevated blood pressure on the 24-hour ambulatory. So this would be a classic white coat hypertension. They only seem to show this response when they're reacting to a stressor, essentially. This is inadvertently a stress reactivity study. And what they found was that white coat hypertension is not benign. They followed these participants for about 5 years, and you can see the white coat hypertension, that's a hazard ratio. And basically, that's a pretty healthy in the bad sense, that's a pretty beefy, maybe way of saying it, hazard ratio showing that there was increased risk for the people that had white coat hypertension compared to those who did not have hypertension. You can see that the other groups also had higher risk, the other groups with hypertension. Now, here's a study that I find really interesting. It was done a number of years ago, but it's such an interesting study that I can't help but present it. This looked at air traffic controllers, and they were interested in this question of what about workplace stress? I mean, you spend a lot of time at your job. What happens if you have workplace stress and if you respond to that workplace stress? And so what they did was they had a hypothesis. They suspected that increased blood pressure reactivity to stress would be an early marker of hypertension. That doesn't necessarily mean it causes hypertension, but it just means if you see this happening, it's a marker, it's a risk factor for hypertension. And so what they did was they went into the place where these folks worked, and for every 20 minutes across 5 hours over 5 different days, so a pretty good sample, they measured workload stress. And they measured this quite objectively. It was a number of planes that the controller was controlling in his or her airspace that were either climbing or descending. So planes that were changing altitude and were taking direction from the air traffic controller. How many of them are there? And then they measured blood pressure. They looked at blood pressure reactivity to see how much of an increase in blood pressure would there be with 0 planes versus 1 plane versus 2 planes and so forth, as a sample size of 218. Then 20 years later, they reevaluated them for development of hypertension. And what they found was that the respondents who were in the highest quartile of systolic blood pressure reactivity, that's that higher number when the heart's pumping, they were at 3.5 times more likely to develop hypertension than those who were in the lowest quartile. So I think that's a really interesting study, and it brings to mind many other studies talking about workplace stress. So stress reactivity does seem to have some predictive effects. Social isolation and loneliness have been associated with a 50% increased risk of cardiovascular disease. But then there are some others, and I'm just going to mention these quickly in the interest of time. But childhood maltreatment or socioeconomic disadvantage are linked to some of the other biological conditions that are precursors for heart disease. And post-traumatic stress disorder, a recent meta-analysis of 151,000 patients found a 61% increased risk of heart disease in patients with PTSD. Depression has been studied for quite a while, maybe one of the original areas of research in this area. Depression, as you may know, is diagnosed twice as common, is thought to be twice as common in women. Now, there could be a multitude of hypotheses as to why that is the case. All of them probably have a little something to say for themselves, and all of them are a bit controversial. So I'll leave that for others to decide. But clearly, this twice as common diagnosis is pretty much universally agreed upon. And we know that depression does presuppose one to an increased risk for heart attacks and stroke, even after you control for some of those other factors that I've mentioned, like the social demographic factors, and also for an increased risk of recurrent heart attack. Anger and hostility have also been studied. These are kind of interesting. Hostility is really thought of as that more chronic, long-term, cynical attitude toward the world, whereas anger is more that explosive event. And both of them, particularly the cynical hostility, have been related to cardiac events. And anxiety, interestingly, anxiety is one of the lesser, sort of a lesser player in all of this in a lot of ways, even though, as we just heard, oftentimes cardiac symptoms are attributed to anxiety. But it does put us at risk for some of the other variables, some of the behaviors that lead to heart disease. And that's what I want to talk about now for just a quick minute are some of the pathways. How can this psychological stuff actually influence heart health? And there's two pathways really. One is the indirect pathway, and this is behaviors. So if you're anxious, and because you're anxious, you smoke, because smoking makes you feel a little better, well, then that's an indirect pathway that leads us to a behavior that leads to a risk for heart disease. Or if you're very depressed and you therefore get no exercise, and you're very sedentary, then that also can be a pathway from depression to a behavior to heart disease. But there are also direct pathways which deal with biological alterations that are related to psychological states. I've listed several of them here. Initially, I thought I'd go into all this, but I decided, you know what, I'm not going to do that. That's just too much and kind of too boring in a way. So we'll pass through that. But there are some of these direct pathways that people are interested in. Now, what about positive psychological states? Is there anything good to be said for all of this, or is it just a bunch of bad news? And there is some good news. Unfortunately, the good news is not as well supported by the data overall, and it hasn't been studied for as long, because psychology for many, many, many years was the study of things that go wrong before we finally decided, hey, you know what? People often do a lot of things right too. And we started studying some of that. Well, I study sense of purpose and meaning, and you can see here from these data, a meta-analysis. Again, that's a study where you bring a bunch of studies together, in this case 10, you kind of put them in the statistical blender and see what you get. And we found that higher purpose in life predicted a 17% decrease in both all-cause mortality or death from any reason, as well as cardiac events. There's also been research on optimism, or is it the absence of pessimism? And that sort of is a hearty debate in the field at this point. But we found some measures that shown, for example, that optimism protected women against the progression of atherosclerosis. And then you can see there another meta-analysis showing decreased risk of initial events and 14% decrease in all-cause mortality related to optimism, and also a smaller study looking at a decreased risk for hospital readmissions. And then finally, a lot of emphasis, a lot of discussion these days about mindfulness. And I won't go into all of what mindfulness may or may not be, but the research so far really kind of shows mindfulness being related more to changes in behaviors that influence risk factors for heart disease. But I suspect as time goes on, there will be more studies in this area and we may learn a little bit more. It's kind of a newer area of work. Well, then our final question was, can your heart affect your psychological state? Can this thing go the other direction? And we know that about 65% of heart attack patients experience some depression. About 20% actually experience major depression. And then I wanted to take just a minute to talk about something called SCAD. SCAD is a spontaneous coronary artery dissection. About 90% of the patients are female in a rather tight age range there. When we first got interested in SCAD, and we were funded from the Ludeman Center, thank you very much for that. When we were first interested in SCAD, it was only a few years ago, and it seemed like almost nobody was talking about it much. And then since then, it's received quite a bit of attention in the news. And former estimates as to the incidence and prevalence of SCAD are really undergoing revision as people are looking for it more. One of our colleagues at Mass General, who works with us on the SCAD research, a cardiologist there, she has started looking for it in any woman under the age of 50 that comes in with what looks like a heart attack. She starts looking for SCAD and she's finding it a lot more often. So we don't know how common it is. It's probably still relatively rare, but it's more common than people thought in the past. Many or most of the women that have SCADs lack traditional risk factors for heart disease, and they often identify an emotional or an intense physical exertion stressor prior to the event. So this is kind of interesting, and it has some effects on the psychological sequelae or the follow-up aspects of having this SCAD event. For example, we find higher than expected rates of anxiety, depression, PTSD, and migraine headaches that impact quality of life in individuals with SCAD. Again, almost all of them women. They have difficulty with a new identity. You know, I didn't have risk factors. I'm young. I'm female. So what gives? Why did I have this condition? Where did it come from? And that can be very difficult, especially if they were very active pre-SCAD. Cardiac rehabilitation is seen as helpful, but it can be demographically challenging if you're in there with a lot of overweight, traditional risk factor men who are older. That could be a challenge in terms of the social setting. We also found in our studies that they're quite unsatisfied with the information that they get and likely to search the internet, always something done at your own peril. 52% said the internet was the most helpful source of information, though, and only 9% said healthcare professionals. And that increases anxiety as well when they don't believe they have solid information. And then the female patients under 50 that we studied had a greater than chance likelihood of feeling that they weren't taken seriously at the emergency department when they presented. Okay, so in conclusion, what's the #1 cause of death for men? You guessed it, heart disease. What's the #1 cause of death for women? You guessed it, heart disease. I fool my class. I teach a cardiovascular health psychology class. They get that wrong every semester when we start out because it just doesn't get quite as much attention as maybe some other diseases do. So what can you do? Well, I'm just going to leave this slide up and you can kind of look it over. It turns out that the lifestyle behaviors that are good for your heart are the same things that are good for your psyche. If you want to treat depression, you could treat your heart and do many of these same things in terms of nutrition, not smoking, don't sweat the small stuff. Hey, by the way, most of it's small stuff. Having a strong social network, having a go-to relaxation strategy that you can use and so forth. All of these can be helpful. We could spend a whole course. We actually do that in my course on all of these things. So there's a lot that can be done. And I want to thank you very much for your attention. You can see my email address up there. And I'm going to just mention a book real quick that I read a few years ago called Heart: A History. Really interesting book. A lot of interesting side stories about discoveries in cardiology and who did what and how it came about, but also some really interesting discussion on emotions and heart health that you might be interested in, written at a very readable, popular level. All right, thank you very much.
Thank you, Dr. Masters. That was great. I'm now going to ask some questions for our three speakers. And I'll address it to one of you, but if other of you have commentary on the questions, please don't hesitate to chime in. So a question about stroke asks, what if you have none of the typical symptoms? This person had a stroke and did not have any of the typical signs while having the stroke. When she went to the ED, she was told she was not having a stroke, and they waited several hours before they performed an MRI CT. She also had one as she was about to be dismissed from the hospital and had no sign other than a sharp headache, like an ice cream freeze.
Yeah, so I would like to say that this is, unfortunately is very uncommon, but it's not. We as ED physicians, with the tools we currently have to assess for stroke, the NIH stroke scale being the largest one, are actually horrible at detecting these atypical, what we consider atypical. And unfortunately, what we're finding out is they're actually not atypical. They're just atypical for men strokes. And so when we look at the stroke scales, they're really good at looking at these large strokes that we typically see in males, but not in females, for the numbness, the weakness, dizziness, headache. We have evidence that says this is how women present, and yet we don't have the tools to detect in the emergency physicians. So I think from my perspective, as a clinician, timing is a big one, of like, how sudden did the symptoms come on? That is a really big red flag, and stressing and trying to advocate for yourself and your loved ones that this isn't a normal pattern of my headache. This isn't normal for me. It was a sudden change. Sometimes can get the attention of ED clinicians, but unfortunately our field is behind here.
And another person also asks, is there more information about stroke symptoms based on gender? It's scary to hear that a person could be misdiagnosed because their symptoms were different because they were.
Unfortunately, the research here is lacking. Like I said, we know that they present differently, and yet we haven't done the research to design new screening tools to better assess for these atypical signs from our screening tools. Until we do that, we're going to continue to miss these. There are some push. So like Colorado actually does a halfway decent job of this in terms of saying, okay, we accept that numbness, tingling, dizziness, severe headache, sudden onset of any of those symptoms could be a stroke. And so they will often try to initiate a stroke protocol early from our triage, but it's still not enough.
I always think the best advice is if you have a doubt, go to the hospital, check it out. Don't sit around and think that anyone will think the less of you for it. It doesn't matter. Go in.
No, and I that is something I definitely advocate with patients of, like, I'd much rather see you early. And even if we see you early after those symptoms, even if we say, well, we're going to wait and get the MRI, sometimes we have that time to get what we consider a hyperacute MRI. So a rapid MRI where we don't delay hours and hours, but we get it within 1-2 hours and then have the option to still intervene early.
Thank you.
One comment about the first question. So that it seems as though the attendee did undergo an MRI CT, which I would assume is negative because she was released without any further evaluation. So I would say if symptoms were persisting, and you can correct me if I'm wrong, Dr. Dylla, but if symptoms were persisting and you had a negative head scan, that it would be reassuring, that you didn't have an active stroke that was ongoing. And yes, it's not great that there's a delay in the obtaining of the scan, but.
Well, and sometimes I think that conversation early on of recognizing that a CT can rule out a bleed, a hemorrhagic stroke. It can't rule out acute ischemic stroke. It can tell you you've had strokes in the past, but that MRI is really what we need to make that diagnosis in the early setting. And so just recognizing that there are limitations of what we can do with the imaging in the ED, but often we'll still have a conversation of like, even if this is a stroke, you're not eligible for TPA, you're not eligible for these other treatment options. And so there may be a delay in how we approach it from an ED perspective because you're not eligible for those acute interventions.
Question for Dr. Tzou is, why do women get anticoagulation treatment less often than men?
That's a great question, which I don't have actual data to support. However, if you look at the risk factors that predict stroke, ischemic stroke, so blood clot forming stroke that Dr. Dylla described, which are the most common in all forms, but also atrial fibrillation, they overlap significantly with bleeding risk for stroke. And being the female is one of those risk factors. And so I think that's in part why some of the lower rates of anticoagulation are offered, prescribed. We think about frailty a lot, and if women are presenting and they're over the age of 75, for instance, with a new diagnosis, and they are perceived to have higher bleeding risks, then that is a common reason. And then the final reason is, just like that first patient I described, they don't perhaps recognize that they have any problem because they're so busy taking care of other things. And either they are not offered the prescription or they're given aspirin. That's a very common thing, which is, as I said, not the same. Or they're just felt to have too high of bleeding risks to move forward with full on anticoagulation. But the appropriate treatment is for oral anticoagulation. And I wish that it were different, the pattern of treatment.
It happens a lot in many types of cardiac disease and diabetes. Women do receive less treatment, even though it's merited and warranted. Dr. Masters, not a question, but a comment. One of the favorite books of this individual is Why Zebras Don't Get Ulcers, one of the best books on the impact of stress by Robert Sapolsky. What do you think? You're muted.
Whoops. There we go. About that. It's only been 2 years of doing Zoom. You'd think I'd have this figured out by now. Robert Sapolsky is one of my heroes. He does really interesting work. I think he's right on. I recommend you read anything he writes. He does an excellent job, and I completely agree. That's one of the theses of that book is what I was talking about with the recovery piece of things. Mammals other than us, when they're done with the stress, they're done. It's over. They've moved on. We maybe have moved on, or maybe we haven't moved on. So yeah, very good. Thanks for that comment, whoever said that. And I hope others, if you haven't seen that book, it's worth a read.
There are several questions about hormone replacement therapy, about symptoms before and after the menopause with regards to reducing risk of stroke. So are there lifestyle differences? What are the hormonal differences? And I think Doctors Dylla and Tzou could address this. And Dr. Masters, if he wants to.
Sure. So we often think of estrogen, endogenous estrogen, so the estrogen that you make normally prior to menopause, as being protective against stroke. However, we also know that exogenous estrogen hormone replacement therapy actually potentially increases your risk of stroke. So it's a little bit of a double-edged sword in how we think of estrogen and stroke, and when and how long you've been on it, and is it a combination with estrogen and progesterone. In terms of lifestyle before and after menopause, I don't know of any specific recommendations other than, trying to still stay healthy, minimize your buildup of atherosclerotic plaques. So not smoking, lose weight, control your diabetes. I don't know, Dr. Tzou, maybe you have a different perspective from the heart side.
With respect to the arrhythmia linked to stroke, or not even just the arrhythmia link, the cardiovascular link. Clearly, women after menopause resemble men more. And so cardiovascular risks for everything kind of increase. With respect to propensity for arrhythmias that lead to stroke, think that there's probably some sort of association, although there's not one that's been directly published to sort of hang one's hat on. I think all the things that Dr. Dylla mentioned with respect to optimizing health for longevity, like well before, reaching the point of, menopause is important. And that includes, healthy habits like those endorsed by the AHA the American Heart Association, American College of Cardiology, for maintaining some level of aerobic exercise daily and trying to maintain or get to a healthy weight if one has not done so already are the ways to try to minimize risk. But it's not, there's not necessarily a link between, for instance, menopause and AFib. There have been links that have been attributed to fluctuations in estrogen and progesterone during a menstrual cycle for premenopausal women, but it's not that clear that it's a straight association with AFib. I think the issue there is that women become more like men in that context, and they're predisposed or disposed then to the same risk factors that predispose to arrhythmias in that population.
Does HRT in women over 60 increase or decrease the risk of stroke or of AFib for that matter?
So it does increase your risk of stroke if you haven't been on it. I don't know about AFib, sorry.
Okay. Yeah, I don't think that's been actually well studied, Judy, but yeah, it is clear that it increases the risk for overall cardiovascular events outside of necessarily arrhythmias.
Wow.
Seems to be protective against like GI cancers, but but that's about it. And symptoms are important.
Of course. How common is SVT happening with sleep apnea?
SVT, so I mentioned how AFib can have a precursor. There's like triggered firing from the atrium, and it basically is like the entity of what I call paroxysmal atrial tachycardia. So in the context of sleep apnea, I think that probably happens a lot. And then that's just like a precursor to AFib most times.
Dr. Masters, one of our attendees, asks about SCAD again. Can you define SCAD?
Define SCAD? SCAD stands for spontaneous coronary artery dissection, and it has to do with, it's hard to do these hands. I wish we were in person with, you have your artery and the walls of the artery get diseased. In some cases, they kind of bulge in or they flap down. And anyway, this causes blood to pool and can cause symptoms of a heart attack or heart disease. But it's not the standard plaque buildup situation that you see in other sort of, what would you call garden variety, I guess, heart disease.
Thank you. We're at the end of our time. I got a really nice comment here that says, I really appreciate the 3 speakers and their dedication to women's health. Can you do a road show to giving further talks?
If I could get out of my dining room to see people in person, maybe we'd give it a go.
Well, there's a start.
Really nice.
I want to thank you all for joining us tonight. We really appreciate your participation. There were a lot of questions and I got to as many as I could, and there were many more for all of you. And I'm sorry that I couldn't get to all of them. A recording of this event and additional resources provided by our speakers can be found at theludemanCenter.org. Please complete the evaluation. We really look at the evaluations. We look to you for guidance on the events that we hold. It's very important to us that our community feel that they are learning from the events and that we are covering the topics you would like to see covered within our areas of focus. We hope to see you at our next Let's Talk in April, and have a good rest of your evening. Thank you so much. And thanks again to our speakers. That was great.
Thank you.
Thank you.
Thank you.